Hello.
Hello. Yeah.
Good evening, sir. Sir, you can start the session, sir, and we open for 30 minutes.
Okay. In 3 minutes time I'll start. It's only
Okay.
8:14. Yeah, right.
Good evening, sir.
Good evening, good evening. Good evening, Raymane. Good evening.
Good evening, sir.
Good evening, Jose. Good evening.
Matthew ആണ് കോട്ടയം.
മനസ്സിലായി.
എന്റെ കസിൻ അവര് പാരന്യൂപ്ലാസ്റ്റിക് പ്രൊഫൈൽ കൊടുത്തു.
അത് കിട്ടി, എനിക്ക് അയച്ചായിരുന്നു അവര്. ഇനി കിട്ടിയത് നെഗറ്റീവ് ആയിരുന്നു. നെഗറ്റീവായി.
ഓക്കെ ഓക്കെ. പെറ്റിന് അപ്പോയിന്റ്മെന്റ് എടുത്തിട്ടുണ്ട്.
ശരി. താങ്ക് യു, മാത്യു. So I think we'll start now.
Okay, sir.
Okay. So good evening to all of you. As usual, I'll start with a short case first. Is my screen seen?
Yes, sir.
Okay, I think there is some problem. Let me once again. Okay. Can we see now?
Oh, yes, sir.
Okay, right. This case is again given by Dr. Samia from Calcutta. It's a short case, ultra short case. It's a story of a 32-year-old hypertensive male. He presented with subtle symptoms of imbalance while getting up from sitting position of acute onset. He had a tendency to fall to right side. Symptoms started on waking from bed. No history of any addiction, no past history of any cardiovascular disease. So sudden onset of imbalance while getting sitting position or short duration. Now this is the video of the patient. When he stands to get him sitting position, he tends to say to one side.
মাঝখানে দাঁড়াও, দুটো পা জোড়া করো। ঠিক দাও। সামনের দিকে ঝুঁকবে। কোন দিকে পড়ে যাবে মনে হচ্ছে? ডান দিকে না বাঁ দিকে? পুরো তাকাও।
Look at the eye. It's got a mild gaze book, nystagmus to it. Not gaze book. fast beating nystagmus to the left side, very subtle nystagmus.
তাকাও
You can see that few jerks only, very difficult to make out. Other extraocular movements were normal.
এদিকে তাকাও এদিকে তাকাও
Ask him to close the eye and open,
উপরে নিচে বন্ধ করে থাকো
and he's asked to open the eyes.
খোলো
Then the eyes tend to
আবার
deviate
চোখটা
from
বন্ধ
right
করো।
side to the left
বন্ধ
side.
করে থাকো খোলো
So that's all the findings.
উপরে উঠে
Rest of the findings normal. All extraocular movements normal. Subtle sustained nystagmus jerks in attempted left gaze. Saccadic lateropulsion to the right side. That when you open the eye tend to deviate from the right to the left side. Tendency to fall to the right side when you get up from sitting position. It's got lateropulsion to the right side. Rest of the cranial normal. No gross objective sensory or motor signs. Tandem gait is impaired. So what is the cytoplegia in this patient?
Lateral medullary syndrome, sir.
Yeah, very good. That's the typical of a right lateral medullary syndrome, or it could be lesion on the contralateral left pons or midbrain or thalamus can also produce the same thing. Okay. Now, what are the findings in this patient? Right lateral saccadic pulsion, ipsy-pulsion, right body lateral pulsion to the right side, pseudovestibular nystagmus. Now, as told before, some in medullary lesion, you can have nystagmus mimicking a peripheral nystagmus with beating only at one direction, that to the opposite direction. So this is the MRI. Okay, you suspect lateral medullary syndrome. Okay, but this flare sequence MRI is normal. MRI the brainstem is normal. But in the mesencephalic region, the mesencephalothalamic region, you can find infarct on the right side. See on the right side. Brain parenchyma normal. Now, what is the localization now? How to explain this finding in this patient?
Diffusion sequencer.
Pardon? Diffusion sequence. I think this is a sequence given by Dr. Sami. I think this is a diffusion sequence. I think so. Now I'll show one more case. Still, it is lateral medullary syndrome. It cannot be that right pontine, right thalamic lesion or thalamomesencephalic lesion cannot explain his lateral pulsion to the right side. I'll explain that later on. The infarct seen in the thalamomesencephalic region was on the scene on the right side. This cannot explain the saccadic lateral pulsion to the right or the lateral pulsion on the body to the right side. So you must have some infarct there in the midbrain and in the medulla, which is not seen in the MRI. So the only thing is you have to then always you have to correlate the clinical finding with the imaging finding. Now I'll show you another patient, a 44-year-old man presented with unsteadiness of gait with tendency to fall to the right side. It's a short case. The moment he's made to stand up, he falls to the right side. Whole trunk goes to the right side. He has no limb attack.
It's going to the right side.
Now he had an infarct in the left pons. See the pyramid in front of the left pons there. And he's falling to the right side. Right. So left pyramidal infarct with contrapulsion. Now this is, I'll tell you about the mechanism of contrapulsion. See, the anatomical structure that is responsible for the sudden tilt of the body is due to lesion in the ascending graviceptive pathway, resulting in imbalance in the roll plane. It tends to rotate one side, fall to one side. There is a roll plane. The direction of subjective visual vertical tilt corresponds with the direction of the body lateropulsion, consistent with an ascending graviceptive pathway. I'll tell you about the pathway. The graviceptive input from the otolith organs are the one which maintain your position of body in relation to gravity. This graviceptive input from the otolith converges with that from the vertical semicircular canals at the level of the vestibular nuclei to subserve the vestibular function in the pitch and the roll plane. These signals are passed on to the oculomotor nuclei and the cortical centers for the perception of verticality. Look at this pathway. See, this is this right side, this left side, from the superior subjective canal, but mainly from the outer leaf, the input go to the ipsilateral vestibular nuclei. From there, it goes to the opposite side and ascend in the MLF, go to the INC for the saccadic lateral pulsion of the eye. Then not saccadic pulsion for the orientation of the eye in relation to gravity. Then some of the fibers go to the thalamus and to the parietal lobe for your subjective visual verticality. Subjective experience your visual vertical. If there is lesion on the left side, here in the below the medulla, in the vestibular nuclei or the ipsilateral side, the tilt will be to the same side. See the body of the person tilting to the same side. When you cross to the opposite side, out it's ascended up in the pons, midbrain, and thalamus, etc. The tilt of the body is to the contralateral side. There is contrapulsion. The lesions in the medulla, as you said, it can be ipsipulsion of the body, ipsipulsion of the eye. Whereas if after crossing, you get contrapulsion of the body. Contrapulsion of the saccadic lateral pulsion contrapulsion may be there. The superior subalapid peduncle is affected. More the lesion above that thing. You cannot get a lateral pulsion of the body in a lesion, a lateral pulsion of the eye in a lesion of the thalamus or above. It should be a connection between the vestibular nuclei and the INC. So in this case, in our case, we found that he has got a lesion on the right paramedian thalamic region that can only produce a lateral pulsion to the left side. Our patient had lateral pulsion to the right side. Not only that, not only the body lateral pulsion, but the secondary lateral pulsion also to the right side. That means it has to be in the left-sided pons or midbrain or thalamus, and it has to be right laminatory syndrome. So what you observed was not responsible for the deficit. There is some other lesion. So brainstem lesion just dorsal to the vestibular nuclei cause controversy, tilts and falls, whereas all lesions caudal to this level cause ipsiversy, tilts and falls. Now sometimes you can have without limb ataxia only axial ipsipulsion. Let's take the second patient had. He had no incoordination. Now body lateral pulsion without limb ataxia was probably due to impairment in the vestibular spinal postural control caused by the lesion of the descending lateral vestibular nucleus. The vestibular nucleus, the lateral nucleus, is the one which sends fibers embed downward to the extensor muscles of the body to maintain the posture against gravity. Body lateral pulsion with limb ataxia was attributable to the lesion of the ascending dorsal spinocerebellar tract or posterior spinocerebellar tract. And this is the site of lesion where you find only an isolated body lateral pulsion without a limb ataxia. That is in the lateral vestibulospinal tract. With ascending, when the posterior spinocerebellar tract is affected, you get lateral pulsion along with limb ataxia. The lateral vestibulospinal tract is considered to play an important role in maintenance of the posture, exerting strong excitatory influence on the extensor muscles and inhibitory influence on the flexor muscles, make your body stand erect. Thus, interruption of the lateral vestibulospinal tract decreases extensor muscle tone of the trunk and limbs on the side of the lesion, which is likely to cause the ipsilateral axial lateral pulsion. The same thing which already told. Okay, that's only short case. Any questions in that case?
Sir, that with limb ataxia, I didn't understand, sir. Lateral pulsion with limb ataxia.
Normally in a ipsilateral cerebellar lesion, what do you get? You get a neocerebellar lesion, or is the ascending spinocerebellar fibers which reaches the cerebellum. You get ipsilateral ataxia, that is ataxia to the side of the body. That is upper limb incoordination as the limb incoordination on one side. Such a patient also can have, when you walk about, fall to the same side. So for example, you think about a left cerebellar lesion per se. When he walks about, he tilts towards the left side. Okay, so he's got a body lateral pulsion there. In addition, you will have limb ataxia. Finger nose syndrome will be positive, lesion will be positive on the left side. On the other hand, isolated lateral pulsion means that he has no limb incoordination. Finger nose test is normal, lesion test is normal, but the moment you make him stand erect, he falls to one side. That means it is not due to the lesion of the cerebellar connections to the limb. It's also because of the postural loss is lost. That is from the otolith organs maintain the posture through the supplying the extensor muscles of the body through the vestibulospinal tract. So when that is lost, you get a only body lateropulsion without a limb ataxia. On the other hand, if the medullary lesion, if the ascending spinothalamic tract is also affected, which goes to the inferior subulnar peduncle, you get lateropulsion as well as ipsilateral ataxia.
Okay, sir.
Okay, that's the difference between the two.
Can the same occur with vestibular nucleus lesions also?
In acute vestibulopathy, you can have a lateropulsion to the same side, but that's only very transitory because the other vestibular nuclei will take over the function, will maintain the compensate. It will get compensated for that. That is, in acute vestibulopathy, you get lateropulsion only for the initial 2-3 days. That when you close the eye, you fall one side. Because since it's a peripheral lesion, there can be compensation by the eye. It will try to maintain your position. Okay. The moment you close the eye, the patient will fall to one side. After 2-3 days, the central compensation will occur with the help of the contralateral labyrinth. So this ipsipulsional tendency to fall to one side will disappear.
Okay.
That is like, therefore, even if it is totally damaged, the patient will not be ataxic at all after 3-4 days.
Can you explain the pseudo-vestibular nystagmus?
Yeah, usually in the case of cerebellar lesion, what you get is that you get a gaze-evoked nystagmus due to lesion of flocculus. That means when you look to the right side, the first component to the right side, look to the left side, first component to the left side. That is a direction changing nystagmus. Okay. In whichever direction you look, the first component to the right side. That's a classical gaze-evoked nystagmus, classically seen vestibular lesions or cerebellar lesions. Sorry, vestibular classically seen floccular lesions or cerebellar lesions. On the other hand, if the labyrinth is affected, peripheral labyrinth is affected, what you get a direction fixed nystagmus. Suppose the left labyrinth is affected, you get a nystagmus beating to the right side. And if you look to the right side, it beats to the right side. Primary position beats to the right side. Look to the left side, also beat to the right side. So in whichever position you turn the eye, to the right or the left, the direction nystagmus is only in one direction, unidirectional. That is classical of a peripheral vestibular nystagmus. So in the central lesion, you don't expect a direction fixed nystagmus. You expect a direction changing nystagmus. In vestibular nucleus also affected, you can have a direction changing nystagmus. Look to the right side, be to the right side, go to the left side, be to the left side. But the point against a cerebellar versus central vestibular is that cerebellar lesion will not produce a primary position nystagmus. In the case of a horizontal nystagmus. On the other hand, vestibular nuclear, central vestibular nuclear affection will produce primary position nystagmus as well as a direction changing nystagmus. The direction, the nystagmus opposite side will be always of larger amplitude compared to the same side. Whereas the cerebellar lesion, the first component, the amplitude in the nystagmus is more to the side of the lesion. If cerebellar lesion is happening on the left side, I get a next case of nystagmus. On look to the right side, beat to the right side. Look to the left side, beat to the left side. The left side will be more amplitude. In central vestibular nystagmus, you again get a direction changing nystagmus, but on contralateral side will be more amplitude, and in addition, you get a primary position nystagmus beat into the opposite side. That is central vestibular nystagmus. The peripheral vestibular nystagmus only on one direction it beats. Since sometimes in lateral syndrome, you get a nystagmus only beating to the contralateral one side. For example, here there is few nystagmus beating only to the left side. No nystagmus in the primary position, no nystagmus look to the right side. Just like a early peripheral vestibulopathy. That is why it is called pseudo-vestibular neuritis. Lateral syndrome can produce this kind of nystagmus. That's why this term called pseudo-vestibular nystagmus. That means it mimics a peripheral vestibular nystagmus.
But it will be persistent and not fatigable.
It's not fatigable, unlike not fatigable.
Okay, thanks.
Okay, shall I go to the next case?
So one more doubt, with the pseudo-vestibular nystagmus, if you get the saccadic lateral pulsion, then it is central only, no?
Very, very good. That's a very important point. See, this, in fact, I had sometime back I showed one case of pseudo-vestibular nystagmus.
Yes, sir. Yes, sir.
I was unable to differentiate whether it's peripheral vestibulopathy or an early lateral medicine. Sometimes the lateral medicine will be so localized to one part. You can only isolated pain loss in the lower limb. Only isolated saccadic lateral pressure. I have seen like that. So that particular patient had a vestibular nystagmus, nystagmus waiting to one side. I was unable to differentiate whether it's perivasculopathy or lateral syndrome. Due to saccadic lateral, close the eye open, it was deviating to the opposite side. That means it's got a saccadic. That made me certain it's a brainstem lesion and not a peripheral vestibular. This is a very good point to differentiate a peripheral, if you get it, peripheral vestibulopathy from central vestibulopathy, because they're very important when you find when a patient comes to you in the OPD with an acute vestibular syndrome to differentiate between peripheral and central.
Sir, I remember
Apart-
that day we discussed
Yeah.
that it should be a part of HINS also, so that it
Right,
gets complete.
exactly.
HINS plus
So,
examination.
right, yeah. HINS plus I call it HINS plus. In addition to the 2 plus, I got a 3 plus also. I
3
added
plus,
this.
yes, sir.
So in lateral medullary syndrome also you the same side ataxia will be there, no, sir? Like
Yeah,
cerebellar.
correct. You'll get it. That is because the involvement of the inferior cerebellar peduncle.
Okay, so then we cannot, when there is no saccadic lateral pulsion, we cannot differentiate cerebellar lateral pulsion from cerebral, lateral medullary, sir?
No, you can, because in lateral, in the case of vestibular involvement, you will not get a limb incoordination. Okay. Limb incoordination will not occur with the vestibular lesion. Only in cerebellar connection lesion, you get a limb incoordination. Limb incoordination, by which we mean finger-nose incoordination and heel-shin incoordination will not occur with a vestibular lesion. That only occurs with the cerebellar lesion.
Sir, in lateral medullary syndrome will not occur, sir? If the
Yeah,
lesion
that's lateral medullary syndrome. You can have a only body lateral pulsion mimicking a peripheral vestibulopathy or lateral pulsion with ipsilateral limb ataxia. That is why I showed the 2 points. If there is sometimes lateral can produce isolated trunk lateral pulsion without limb ataxia, then the lesion is the descending vestibular spinal tract. If that patient has got, in addition to the lateral pulsion, ipsilateral ataxia, limb ataxia, think of a posterior spinocerebellar tract involvement. Inferior cerebellar peduncle.
Thank you, sir.
Sir, in lateral syndrome, the ataxia is always due to the ACP involvement or hemispheric involvement. Sometimes you get hemispheric involvement also.
Yeah, that's absolutely correct. Because ultimately, the inferior cerebellar peduncle input goes to the cerebellar hemisphere only. That also can be the same thing. But even without involvement
Is there any
cerebellar
point
hemisphere,
how to differentiate between a cerebellar hemispheric and peduncular or inferior or
no,
superior cerebellar peduncular involvement? Is there any difference?
That's difficult to differentiate. Usually, if cerebellar cortical involvement per se will not produce much of a symptom at all. It is a basal cerebellar nuclei effect which is going to cause problem, or it's suffering input through the peduncles. The peduncular lesion is more polysymptomatic than a pure cerebellar cortical lesion. I'm not talking about subcortical. They are involved, they'll be more devastating. For example, if the dentatorubral tract is affected, you have severe upper limb incoordination. But if it is cerebellar hemisphere alone is affected without the nuclear involvement, the attacks will be minimal.
All cerebellar peduncles can produce ataxia.
Yes.
Superior
Any
and inferior.
cerebellar peduncle can produce attacks.
So between these peduncles, is there any difference?
Yeah,
more
there's
of
of course
the upper
there.
limb involvement
Because
and inferior.
I'll tell you, because in the case of inferior cerebellar peduncle, the incoordination of the upper limb is minimal, more of a lower limb incoordination. In the case of superior peduncle lesions, it is upper limb which is markedly affected with intention tremor and all. Because the main outflow tract from the dentatorubral tract lesion producing an upper limb incoordination more than the lower limb incoordination. Same with Beilchowsky epidemic lesions, because ultimately if you talk the fontocerebellar control from the prefrontal motor cortex from the pontine nuclei cross the opposite to peduncle, reach the cerebellar hemisphere, Purkinje fibers go to the dentate nucleus, then the dendrotubro, dendrothalamic outflow, and reaches the motor cortex. Anywhere the loop is affected, it is upper limb which is more affected. On the other hand, if the inferior peduncle is affected, it is lower limb which is more affected.
Okay, sir.
Sir, lower limb incoordination just means heel knee incoordination and not
Correct.
gait incoordination, sir. Right, sir?
No, heel knee incoordination invariably produce gait ataxia to the same side. Suppose got incoordination the left lower limb. When walking about also, will tend to stay to the same side.
Okay,
That is
sir.
a cerebellar lesion one side, the patient tends to stay to one side. Because that limb is not working in a coordinated fashion.
Thank you,
Sir,
sir.
acute vestibulopathy can also produce finger nose test incoordination, like, sir.
No, vestibular tract involvement will not, vestibular spinal tract not produce finger nose incoordination.
Sir, De Jong, they have given that
No,
FNT can
no.
be impaired then.
No, I'll tell you, flocranial lobe is different. Flocranial lobe is entirely different. Whereas
No,
that
sir, no.
produces
I'm telling you, in acute vestibulopathy itself, sir.
yeah, it cannot produce a limb incoordination at all. When you stand, the patient can tilt to one side. If you have incoordination upper and lower limb, it cannot occur with the vestibular nucleus involvement. I'll tell you the reason why. Because if you take the three main functions of the flocranial lobe, where the labyrinth is connected, labyrinth is the vestibular cerebellum, which connected to the flocranial lobe. The flocranial lobe is for maintaining posture and equilibrium, not for coordination. If you knock out the flocranial lobe, you will not get a limb ataxia. You will not have any problem. Only problem, they cannot sit and stand because you'll be swaying by the time. Because you have to, and patients are unable to maintain your position in relation to gravity. That is in flocranial limb centers. When you lie down and examine the patient, he will not be having any incoordination at all. No limb incoordination, upper limb incoordination, the heels will be negative. But the moment you wait to sit up, you will be having fungal ataxia and gait ataxia, because you cannot maintain the posture and equilibrium. That is the function of the flocranial lobe. The limb incoordination is by the neocerebellum and the anterior lobe, where the lower limb spinocerebellar fibers end. In anterior lobe lesions, you get gait ataxia as well as lower limb incoordination, because the input from the lower limb spinocerebellar tract ultimately end in the anterior lobe. You got the point? Yeah.
Yes, sir. Sir, one more doubt, sir. In anterosuperior cerebellum is the one which controls the lower limb and gait, sir. So,
Correct.
the anterosuperior cerebellum is connected to the brainstem via the superior cerebellar peduncle. So, we thought that the superior cerebellar peduncle is involved. It causes more of lower limb ataxia.
No, the other way around. See, I'll tell you that the lower limb fibers, spinocerebellar fibers, end in the anterior lobe of the cerebellum. Okay. There are two spinocerebellar fibers. One is the posterior spinocerebellar tract, the anterior spinocerebellar tract. The posterior spinocerebellar tract go through the inferior cerebellar peduncle. That is the main one. The other is the anterior spinocerebellar tract, which goes up to the midbrain, recrosses and come down to the superior cerebellar peduncle. But that is one input for that. But there is already has got a major input to the posterior and inferior cerebellar peduncle. So that when that is spared, lower limb will always be spared. That's what I said. Upper limb incoordination is more for the dentate superior cerebellar, because superior cerebellar peduncle contain not only this particular afferent fibers in the lower limb, but also major outflow for the coordination for the upper and lower limb. That is from the dentate to thalamic control. That is from the dentate nucleus. That goes through the superior cerebellar peduncle. When that is knocked out, you will have both upper and lower limb, normally for the upper limb.
Okay, sir. Okay, sir.
But lower limb gets input, right? It's spared is because it is reaching the inferior subellar peduncle, reaching the anterior lobe, not to the superior subellar peduncle. It reaches through the anterior subellar, but that's only part of it. Major part is by the inferior subellar peduncle.
Okay.
So at the site of crossing of the superior cerebellar peduncle, if there is a lesion, can we get a gait ataxia as a sole manifestation?
You can have, because it is in the crossing economy, both fibers can be affected. You'll get gait ataxia also. In crossing, the ACP is affected means you get a bilateral limb ataxia, bilateral limb ataxia, as well as gait ataxia. Because both sides is knocked out. Bilateral limb incoordination. That means he's got a bilateral ataxia. And obviously gait ataxia also.
But the inferior cerebellar peduncle is spared, so
Yeah, inferior peduncle is spread, but you know the role of the neocerebellum is coordination not only for the input but coordination the upper and lower limb. See that also will be affected. In that way, it will produce ataxia. But in that case, the lower limb will be little better than the upper limb in coordination. Because dendrothalamic tract is influencing not only the upper limb, but also lower limb also. It controls any body part for a coordination, for the upper limb or lower limb.
Sir, about this Meniere's disease, sir, when they fall, like, do they have a side preference or something?
Which one? Which one?
Meniere's crisis.
Meniere's crisis usually we do not, and I don't know the side preference. They suddenly fall to one direction. Which direction it fall depending upon which canal is affected. It is actually canal is affected, though not had canal, the otolith is affected. See, it's actually in the case of what do you call in a Tomarkin's crisis, it is a endolymphatic heterops occurring in the otolith, not in the subsacral canal. They don't get vertigo. They just fall to one side because your maintenance of body against gravity is suddenly disaffected. As told before, the otolith organ is the one which maintains the position relation to gravity. When that heterops occur in that particular part, depending upon whether utricle is affected, sacral is affected, in which brain is affected, when heterops occur, that tilt will vary. Okay, regarding the previous clarification, why the both are affected in superior peduncle in a peduncle, because the coordination of the cerebellar thing is from the dentate nucleus, from the neocerebral dentate nucleus. As told before, it receives its input from the prefrontal cortex through the frontal nuclear complex cerebellum. Through the dentate nucleus, it influences the motor cortex for all coordination movements. It actually, even before a motor act is contemplated, it pre-programs for the motor act. That is why the dendrothalamic tract is occurring, even before you do the act. Okay, the spinocerebellar tract from the periphery, the progressive input is giving only one arm supplying that thing. Because the cerebellum is controlling with the input from the labyrinth for the position against cavity. From the coordination, one of the input is from the periphery, the other from the vision. All the three input is fed in the cerebellum. Ultimately, the control, main center is controlling it is through the dendrothalamic tract. And the intermediate with the globus and intermediate nucleus, again producing an online control. The other is a pre-programming is by the dendrotubral. Online control is by the interpositous nucleus. So suppose you want to control immediately, then it is by the online control. Even before you do a task, it gets the action is planned, programmed. Okay, shall I go to the next case?
Okay, sir.
Yes.
Okay. It's also a little long case. It also makes you think that we have to concentrate very clearly in this patient. 6 weeks, this 28-year-old man, 6 weeks back, he noticed binocular diplopia on looking to the right side. It was a vertical diplopia. He consulted a neurologist and was put on medication, and his diplopia improved totally over a period of 2 weeks. He remained asymptomatic for next 2 weeks. Now, for the last 2 weeks, he developed diplopia on to the left side. Again, that also is vertical according to him. No other complaint. No headache. Now, before that, in this particular case, I brought you not to make a etiological diagnosis, but to approach the problem, how to sort out the problem of vertical diplopia. That is why basically brought this patient. No previous history of a neurological deficits. So this is the video of the patient. Look very carefully. It's got a bilateral ptosis. Look to the left side, right eye fails to adduct. Look to the right side, there is disconjugation, which you will see very clearly now. Looking up is okay. Look to the left side, right fails to adduct. Looking down and out. Now down. Now look to the right side and down. And to the right side. Now look at the position of the right eye and the left eye. Okay, I'll play the video once again. I'll be showing it again to make you understand simply.
ലൈറ്റ് എവിടെ പോകുന്നു അവിടെ നോക്കുക. ഇവിടെ നോക്കുക, ഇവിടെ നോക്കുക. ഇവിടെ നോക്കുക, ഇവിടെ ഞെട്ടം നോക്കുക. ഇവിടെ ഇവിടെ നോക്കണേ. താഴെ ഇങ്ങോട്ട് എട്ട് നോക്കിക്ക്, മുകളിലോട്ട് നോക്ക്.
Okay, and any thoughts about the ocular movement? Before that, so the pupil is normal, reacting to light. Okay, it will be difficult, so I'll analyze one by one. Let's first analyze which are the most weak in this patient. So let's first analyze the problem. It's called bilateral ptosis, right? So what is the first question? Is it LPS paralysis or not? Or some other problem? What test will you do? Simple question.
Correctable or not?
Correct. That's the first thing. So all questions are very simple and straightforward, but I mean basic questions. So first question, what is to do? Correctable or not? If it is correctable, it is not LPS. This is very crucial here in our patient because he's got a middle rectus weakness on the right side. We want to know whether that's a part of the third nerve or not. So what is will you do? It's a correctable. You can see it's totally corrected. So it is not a LPS paralysis. It may be congenital. We do not know. See, this looking straight and looking upward. You can see it is corrected. Now, could this ptosis due to myasthenia? Possible, right? Because in myasthenia, always it can be correctable at some times when the patient is not fatigued. So you have to, sometimes it may be open, sometimes it may be closed. So you got a variable ptosis in myasthenia. So what will you do now to find out myasthenia or not?
Fatigability.
Fatigability. So all simple questions, just a fatigability. So look for the fatigability. It is not fatigable.
കണ്ണ് വേദനിച്ചാലും ശരി കണ്ണടയ്ക്കരുത് കേട്ടോ. ശരി.
So it is not fatigable. So ptosis does not appear to be due to myasthenia. It's most likely congenital. So we leave it aside. Now, rest of the extraocular muscle examination. Now, he's looking to the left side. This is a position of the eye on looking to the left side. Or looking to the right side. Right side, you find the left eye is down, right eye is up. Now, let us see the first one. So, what does it indicate?
Right medial rectus.
Right medial rectus. Or it can be INO also. That we can do the convergent is differentiate the two. But since other muscles are affected, most likely medial rectus is affected. So that part is settled out. Right medial rectus weakness. Now the problem now, here now, which muscle is weak?
Right inferior rectus.
Right inferior rectus. Okay, why not left inferior oblique?
That also is possible.
Correct. So there are two possibilities. See, we do not know whether he's looking with the right eye or looking with the left eye. Okay, which is the dominant eye is looking. So right eye is up, left eye is down. Which is abnormal, we do not know. Which is paralyzed, we do not know. So you have to keep both the possibilities. The right eye is affected, it is inferior is affected. The left eye is affected, the corresponding yoke muscle is inferior oblique is affected. Okay. That the eye is in the downward position. These are the two things, not yoke muscle. There are two possibilities. So weakness right inferior rectus, left inferior oblique. Correct? Which one is weak in this patient? But in the history wise, you can differentiate what question will you ask? Simple question.
On looking
No,
to right or left.
Injection, Diplopia is maximum.
Diplopia is maximum look to the right side. That is it. The middle rectus is forgettable.
Tilt.
Just asking the before coming to the head tilt.
Obliquity of the image.
Okay, obliquity of the image you can ask. But again, you can't differentiate between inferior rectus and superior oblique. Both will be a obliquity. More commonly, oblique muscles. Because the primary action of the oblique is torsal movements. The vertical secondary action is only the torsal movement. A very simple question. So this is very easy. Suppose he has got a diplopia on looking down and out more is inferior rectus. If it's inferior oblique, diplopia should be more on looking up and out. Correct?
Yes, sir.
Yeah, because left inferior, what is actually left inferior oblique? It is elevates the eye in the adducted position. So looking up, it will be more problematic. On the other inferior, what is actually inferior rectus? Looking downwards. It will deploy more on looking down. So in this position, if he says his diplopia is more on looking down and out, that means inferior rectus is weak. If he's telling no, it is not, my diplopia is more on looking up and out, inferior oblique is weak. Correct?
Difficulty walking downstairs.
Yeah, but that's there. That's not for superior inferior oblique, that's superior oblique only.
Okay.
It also occur with inferior rectus, more for superior oblique. But a more objective, this is a simple thing. Okay. The left inferior oblique is weak. Diplopia should have been more on looking up and looking to the right side. Correct? Inferior rectus is weak. Diplopia should have been more on looking down and looking to the right. Okay, but the simple question, simple answer is that diplopia will be more when the patient looks in the direction of the paralyzed muscle. Okay. What is the direction of the inferior rectus? Downward. At inferior oblique, upward. So diplopia, asking the patient in which direction, up or down, you can differentiate the two. Is it clear that this much? Okay. So he was not, however, he was not very sure about it. This very often happens when you examine the patient. He will not tell. Sometimes he will tell, yeah, it is now, it is more. Sometimes, now it is more. You get confused. When you start seeing the patient, they'll confuse you. So you cannot differentiate the two. Here again, this is the same thing happened. Now, what else we do to differentiate the two?
Tilt. Head rotation.
One thing first I did was ask him to draw the images. Okay. This again, little bit concentrate very carefully. And this is how you draw the false image. The one on the top is which I have drawn. The one below is the where the false image, that is, the false image, the left side of the false image is tilted down, that is rotated to the left side. This is how it's drawn the image. You can be from the person's side. Imagine that you are the patient. You are seeing the line. You are seeing the line. Okay, that line, the one, top one is the one which I have drawn for him. The correct line, the true image. The one on the down is the false image is perceiving that belong to either A which we do not. That's a false image. And that false image is on the left side of the false image is tilted down and to the left like this with an arrow pointing to the right. Okay, this is a false image I have put it in yellow color. Okay, which muscle could be the problem here? Which muscle could be the problem?
Left inferior oblique, sir.
Left inferior oblique, correct. Why not the right superior oblique? The observer also produce the same thing. I will point the same thing, but right superior oblique is not in our list. Our list has two muscles: inferior oblique versus right left inferior oblique, right superior. But let us see. Let's analyze the problem. Now, so imagine you are the patient. You are looking the false image tilted to the left with the arrow pointing to the right. Correct? Just shown. The false image can belong to either the right eye or the left. This is how to approach. We do not know to which image eye this image, false image belongs. But we know that is caused by the faulty eye. If the false image is caused by the right eye, the false image is internally rotated with respect to the right eye. Correct? Suppose you imagine that your right eye, that inferior rectus, whatever it is, weak. That image is producing a false image with that line tilted the left hand downward. That is we can call internally rotated, the image that we cannot ideally clearly rotate, but tilted down. What does that mean? That means the right is rotated outward, externally rotated. The image is going down because the perceived image is always the opposite to the direct movement of the eye. So the right eye is externally rotated. Okay. Then only you can perceive image tilted to the downward like that. So that means that if the eyeball is externally rotated, it should be one of the internal rotators are weak. Then only the eyeball can go into external rotation. One of the internal rotators, which are the internal rotators of the eye? Superior oblique and superior rectus, correct? So either one of them can produce this kind of phenomena in this patient. False image. Okay. In our patient, we are suspecting a right inferior rectus and left inferior oblique. That means right eye is not fault. Here, this is not a case of right superior oblique because that right superior oblique we do not think in the first examination because that is not the position of the eye in the right superior oblique. But this tilt can occur with the right superior oblique, but that was not our question in hand. Our question was whether the previous one, right inferior rectus, left inferior. The answer is like, see, if the right inferior rectus is weak, as we thought in our patient, the eye goes into intorsion because in inferior rectus is intorted. When the eye goes in intorted, what will happen? The image, false image will be rotated the opposite side. That means the perceived image should have gone on to extorsion. That means the left portion should have gone up. The right end of the false image should have been tilted down, or the left end should have gone up. He should have perceived like this. Okay. So if right inferior rectus has thought when our patient is weak, the false image should have been like this. This is not what the patient has drawn. He has drawn the other way around. So why now we can say that it is not due to an inferior rectus weakness on the right side. Let us see the false image is the same thing which is shown. If the false image is caused by the left eye, that means the left hand is tilted down. The eye should be internally rotated to produce a false image tilted down onto the left side. False image means that left eye should have been turned internally rotated, intorted. Then only you can produce a false image tilted downward with the left eye. The false image externally rotated with respect to the left eye. That means one of the external rotators alignment is weak. You got the point? So left inferior rectus or left inferior oblique, both are external rotators. So what the TD between which you consider was left inferior oblique versus right inferior rectus. So in our patient, we are suspecting left inferior oblique, and that means left eye is at fault. I don't know whether you understood what I meant, what I have discussed. Have you understood this one? Because the perceived image is opposite to the rotation. The eyeball, suppose imagine classical superior oblique palsy, imagine. Okay, right side. That eye will be externally rotated because superior oblique is internally rotated. The right is externally rotated means the image which perceived will be internally rotated. So the false image will be left side will be tilted down, arrow pointing to the right side. That is an arrow point right side superior oblique. Okay. Here let us see on the left side. Here the left side of the image is tilted down, something like extortion of the image. Actually, imagine that extorted. So what will happen? The eye should be indorted to produce a false image like this. Left eye should be indorted. If left side remain indorted, what should be happening? One of the external rotators has to be weak. The external rotators are inferior rectus and inferior oblique. So inferior oblique is weak, what will happen? The external rotator is weak, eye goes in indorsion, the false image will be tilted to the same direction, tilted down. So now this tells you that he has got an inferior oblique weakness. See, if left inferior oblique is weak, the left eye goes into indorsion since inferior rectus is next order. That means the perceived image is opposite to the eyeball rotation. The left hand of the image should have been tilted down. It should have perceived like this. And that is what is perceived. So this test shows you that the patient has got an inferior oblique weakness. So that means that between the two culprit muscles, right inferior rectus or the left inferior oblique, left one is at fault, that is left inferior oblique. So now we know it's left inferior oblique. Now, what else will you do? But one problem with asking the patient to learn the false image, the line of the false image is that it all is purely subjective. Sometimes he may draw crosswise, sometimes we may be mistaken that way. So it's not very foolproof. Objectivity is not there. Subjective. It all depends upon how he has drawn. So if he has fooled you, then you are at lost. That's a problem with asking the patient to draw the line. Any that test you can do, more objective.
Maddox wrote, sir.
Red green plus.
No, not red green glands. Okay. Again, that will not differentiate the two. You can differentiate. Red green glands can differentiate. That you can do. But other things which you can do.
Maddox wrote, sir.
No, that will not help. Simple bedside test Beilchowsky segmentation. Yeah, and I'll tell you what is this test. Now let us see the patient's history.
ഇങ്ങനെ ഞാൻ വെക്കുമ്പോഴും ഇങ്ങോട്ട് തിരിയുമ്പോഴും ആ ഡിസബിലിറ്റി സെയിം ആണ്.
ഈ സൈഡിലോട്ട് തിരിയുമ്പോൾ ഡിസബിലിറ്റി ഉണ്ട് ചെറുതായിട്ട്. ലെഫ്റ്റിലോട്ട് നോക്കുമ്പോൾ
അത് ഇങ്ങനെ വെക്കുന്ന നോക്കി ഇപ്പം ബുദ്ധിമുട്ട് കൂടുതലുണ്ട്.
അതെ,
എന്നെ നോക്കിക്കൊണ്ടിരിക്കേ ഇപ്പം എന്നെ നോക്കുന്നതും
ബുദ്ധിമുട്ടാണ്.
ഇപ്പം നോക്കും. ഓക്കെ, ഇപ്പം ഓക്കെയാണ് അല്ലേ? ശരി.
Okay, did you answer what he meant? See, he said this is the situation where he's more disabled. Diplopia is present. In this position, diplopia is not present. What does it tell you?
Left external rotation is weak, sir.
Correct. That's the answer. That means suppose imagine you, the first picture. You are turning the head to the right side means what? You are putting the right indortus into action, left external into action. Right? That's a position in which has got more disability. So one of the external rotators is weak means that's where it's complaining of diplopia. Suppose you put the head to the left side, left indortus are acting, right externus are acting. There he has no diplopia. That means it is not because that means there if right inferior rectus should have been weak, diplopia should be more on tilting to the left side. Here the other way around. I think it make you understand. The very simple basic principle is that when you rotate the head to say, I'm standing like that, can you see my face? Rotating the left side mean I'm lifting left side. The left eye should indort, right eye should extort. Okay, that's what's happened. Turn the right side, right eye indort, left eye extorts. This is the first step. He has got diplopia on turning head to the right like this. Right? That means that one of the muscles producing that torsal movement will be more effective. So what are the indorters on turn to the right side, right indorters are acting or left external. So either one of the indorters should be weak or one of the external rotators to be weak. The internal rotator is the superior oblique. This can occur with superior oblique palsy, but also with the left inferior rectum, because inferior rectus is an indort. These are the two things. But superior oblique is not ever in the list. Our list has got a inferior oblique on the right side, or the extort is on the side, or the other thing. So here inferior oblique is also an extort. So inferior oblique is at fault. And let us see other way around. On turning to the left side, like this, I have no diplopia. Left indorter is acting, right extorter is acting. Right? Which is the right extorter? Right inferior rectum. That suspected is weak. Diplopia should have been there, but it's no diplopia. That means right inferior rectus is not at fault. The left eye is indorter. Again, we are not coming to the question. That is not affected at all. We are not suspecting at all. So what happened? That has again told you that the lesion is in the left inferior oblique. That is, on rotating to the right side, diplopia is worse. On rotating to the right side, right eye goes in intorsion and left eye goes in extorsion. That means one of the indorter of the right eye or one of the external rotor is weak, because on rotating to the right side, it is worse. Right indorters are superior oblique and superior right superior rectus. We do not suspect weakness of either superior oblique or superior rectus. But the left extorters are, the same time, left extorters are acting, are left eye are left inferior rectus, inferior oblique. The muscle suspected of case can be either right inferior rectus or left inferior oblique. Right LB is not coming here. So what is happening? Our patient's got left inferior oblique weakness. That again tells you that the lesion is on the left side and not on the right side. Is it very clear or is it complicated? Anyway, this is one of the methods to differentiate the two. It's very simple actually. Just think about the torsal movement and think about the muscles, then you will get the answer. So what other test will you do? So since we are suspecting what? Either right inferior rectus is weak, on looking down, what should happen to the eye? Suppose, forget about all these things. My right inferior rectus is weak. Okay. It's paralyzed. Superior oblique is normal. Looking down, what should happen to the eye?
Diplopia should occur.
Right eye should go to intorsion, correct? Because on looking down, which are the muscles acting? Inferior rectus and superior oblique. Okay. Inferior rectus is an extorter, superior oblique is an indorter. When both muscles are acting, I will go straight downward without any intorsion or extortion, because it's cancelled out. One is an indorter, that is extorter. Inferior rectus is extorter, superior oblique is indorter. That will be cancelled out. When one is affected, the other only will be acting. Suppose my inferior rectus is weak. Now the downward movement is caused by only the action of the superior oblique. So in effective body downward movement, what will happen? Eye goes in the intorsion because the inferior rectus is not that what is a counter extorsion. You can perceive a intorsion movement of the eye. On the other hand, if superior oblique is the muscle which has been affected in this patient looking down, I would have gone on to extorsion. Okay.
Okay, sir.
Okay. In superior oblique also you get head tilt to the opposite side. There again, what will you look on looking down? The eye will go into extorsion. So I look for the just for There is no external dorsal movement here on the right eye. Because that shows the right eye is not affected. It is going straight down. I should have also looking up and look for the dorsal movement because of the putting the inferior oblique in the. I did not do that. This means right inferior rectus is not weak. Okay, you understood. On looking down, I'm looking for the inferior rectus and inferior oblique. The other muscles, no. Inferior rectus is depressed. Inferior oblique is elevated. So as about looking down, you look for the dorsal movement. If right inferior rectus is weak, that should have gone on to dorsal. Here there is no dorsal movement. That means inferior rectus is not weak. Then I should have looked for inferior oblique contract. On looking up, I should have looked for the dorsal movement. Looking out, what are the elevators, superior rectus and the inferior oblique. Inferior oblique is weak, the superior rectus is the one only acting, that will produce dorsal movement. If superior rectus is weak, the inferior rectus is acting, that should go into external movement. Looking up. Induction testing is not required because that cannot differentiate INO versus middle rectus weakness. Only in concomitant skin we can differentiate. But even with eye closure, that is that movement is normal. Anyway, rest of the exercises in the rest of the time all normal. And I think if some of you have not understood this thing which I mentioned, just go and think about the action. Surely you'll get it. But you have to think about quietly think about the ocular movements and the yoke muscle, how they act. Then you will get the answer. Only thing, remember that the perceived image is opposite to the rotation of the eye. My right eye is externally rotated, mean the line which is perceived tilted to the opposite direction. That's the only thing to remember. Now, where is the localization here? The distribution of the weakness, right medial rectus and left inferior does not favor a nerve lesion, correct? Two, you can't think of a partial nerve lesion on one side, partial lesion on the other side. Very, very odd combination. So what should you suspect?
Neuromuscular junction.
Correct. This is the pattern we get neuromuscular junction. So the culprit we could have, if on the other hand, if right inferior rectus had been weak, then we could have thought of partial third nerve. That is very well possible. So what test you need? RNS was done. It was negative. This is RNS negative. Then what do you want to do?
Can we use
Antibodies.
iSpec test for the medial rectus movement, like ptosis?
I did not get you. Pardon?
iSpec test that you do for ptosis.
Right.
Can we do it for a
iSpec.
medial rectus movement? Whether it improves?
Yeah, of course you can do, but most of the time it can't be very fruitful. iSpec is good for only for ptosis. Medial rectus, sometimes it may get, it cannot do that. I don't think it will be nystagmus. That's what I usually do for ocular movement. Nystagmus test, that's more potent than iSpec test.
Did he have paradoxical ptosis?
No, he did not have paradoxical ptosis because his both eyes are corrected upon looking up.
Okay.
No, the MRI was done already. It came with an MRI. Brain normal, because tectal lesions can mimic myasthenic syndrome sometimes. Contrast was also done to find out any infiltrating lesion on the meninges like an IgG4 disease. An orbital MRI was also normal. There is no atrophy or hypertrophy of the muscles. To think of a restrictive ophthalmopathy. Then what are the tests you need?
Antibody testing.
ACH and antibody was also negative.
Musk antibody, sir.
Musk antibody was not done. No, this I didn't know. This patient came with all these tests. Engavian negative. So this is the test I planned. I want a neostigmine test, CT test, and other antibody LRP. This is the I had in mind. So I called him for admission. He did not turn up for admission. That's a story. No, the main idea of bringing the patient is not to make a diagnosis here, to find out the localization of the culprit muscle in ocular muscle examination. So any
oral tablets can you give for some time, like 2 weeks, and then check?
He was initially given steroids. That produces improvement. Even myasthenia also patient can improve with steroid.
With periodistic, if he improves, then we can be sure.
Right, but that was not given initially, because in fact I want to start periodistic after doing the neostigmine. They'll be more comfortable. I usually do that before starting that.
Sir, in this case, right medial rectus and right inferior oblique are weak, no, sir?
Left inferior oblique. Not right,
Okay,
left inferior.
Okay, sir.
Commonest muscle involved in myasthenia is medial rectus.
Yeah, that's the maximally apparent muscle is medial rectus. Okay. Any queries regarding that Beilchowsky's test and all, then you can ask me. One of the usual exam question asked is that how will you examine for superior oblique palsy in Turner paralysis? Correct?
So look for
That is
cyclotorsion. Conjunctival vessels, you have to trace a conjunctival vessel. You have to look for cyclotorsion, sir.
for the intorsion of that eye. But the thing you have to understand is that intorsion which you see is not because of because superior oblique is acting, but because the right inferior rectus, same side inferior rectus is weak. Suppose you got a partial third nerve involvement with sparing of inferior rectus, only medial rectus alone is affected. You will not get a torsional movement looking down. You understand that point? Why you are getting a torsional movement, intorsional movement looking down is because the inferior rectus is weak. Normally also when you look down, superior oblique is acting, that will not produce intorsion. Why? Because the inferior rectus prevent you from intorsion because that is an extorter. So in Turner palsy, when the superior oblique is intact, showing intorsion is intact, its superior oblique is intact is because the weakness of the inferior rectus caused by the Turner palsy. Other muscle paralysis caused by Turner palsy will not result in intorsion of the eye if superior oblique is active. Is it clear to you?
Yes, sir.
That's the point I was trying to look at initially. I want looking down to find out whether the eye is going to torsional movement to find out one of the muscle is weak or not. Okay, so I'll go with shall I show one more short case?
Yes, sir.
Yes, sir.
Yes, sir.
He came with complaint that he felt something. He came with felt some twitching movements to the right eyelids for the last 1 month. 19-year-old boy. The mother noticed some tremulous movement in the right cheek, which she said it was persisting during sleep. That is only complaint. He has no other complaint. It's only for 1 month duration. So look at the face of the patient. Look at the lower lip and lower eyelid.
ഞാൻ ഉറക്കത്തിൽ ശ്രദ്ധിക്കും അന്നേരമാണ് ഇങ്ങോട്ടൊക്കെ ഉണ്ടെന്നത് ഞാൻ ഉറങ്ങിക്കിടക്കുമ്പോഴും അതുണ്ട്
Did you see the movement in the lower lip? I'll show it once again. Look at the right lower eyelid as well as the in and around the lips on the right side.
ഇപ്പോൾ പിരിവുണ്ട്. അപ്പൊ ഞാൻ ഉറക്കത്തിൽ ശ്രദ്ധിക്കും, അന്നേരമാണ് ഇങ്ങോട്ടൊക്കെ
It's also there in the upper part of the eyebrow also on the right side.
അതുണ്ട്.
But mainly in the lip region. So, what do you think the patient is having? No other finding.
Hemifacial spasm.
Any families, sir?
No family history. No, here it's not like it's not a spasm like that. It's not going like that. It's something like a
Myokymia.
something mimicking a fasciculation, but it's not a fasciculation because it's something like a rippling type of like a
Facial myokymia.
facial myokymia. Okay, let us see whether it's myokymia or not after examining this thing. Seen as normal. So what this is another case. Facial myokymia. He had this is look at the right eye. He also got a facial pulse on the right side. Look at the cheek muscle. Something like a bag of worm inside that cheek. Okay.
So is it a Pontine glioma or something, sir?
I'll come to that. Okay. So what test you need now to confirm what till you do?
EMG.
Okay. Let's see the EMG I did from the lower part. See very peculiar sound here.
Riving injury.
What do you think?
Pseudo-myotonic discharges.
Pseudo-myotonic discharge. That will be a pinging sound.
Riving injury.
No, this is the something. What is the classical EMG appearance in myokymia? Marching sound, like the marching sound, like a parade marching. But here, does it look like a marching with a faster frequency than march? We do not know. Okay, let us see. Is it like a marching sound with faster frequency? One march, another march. Okay, right. Now let us see this one from the right orbicularis oculi. Now we can make a diagnosis. That's a typical myokymia. It's got a fast march as well as typical. That's a marching sound. Between fast frequency comes. This is the classical marching sound of a myokymia. Soldiers marching.
Pseudo-myotonic discharges also.
No, that again, that fast frequency sound is also typical myokymia fashion. Fast frequency will also come in a typical fashion. It's also myokymic discharges occurring at a faster frequency. So it's a myokymia. Let us say MRI of this patient. This is the flare. This is the 3D flare. Contrast, no contrast enhanced. What is the diagnosis?
So if I take spontaneous glioma.
Yeah, it's a pilocytic acid. See, you can make it out very clearly on the medullary MCP mass effect. See, look at the cis sequence. You can see that it is in fact a large tumor extending in the pons, medulla, and the MCP. See the asymmetry of the medulla now. See, the right side is bulky. See, the peduncle is invisible and peduncle is bulky.
Right.
Is bulky and the right. See, it's a log. See, in fact, the previous patient also had a pontine glioma. So, in fact, as Umar was telling, if you look at the literature, there are two conditions they mention. If you do patient myokymia, two conditions foremost. One is glioma, the other is demyelination. These are the two things we commonly find in myokymia. But this is a medicine literature. But we don't usually see myokymia that often. In so many tumors, we don't see that. But these are the two common causes just mentioned in the literature. So unfortunately, we cannot do much for this patient. So when you get a myokymia, always investigate. MRI is a must. Unlike hemifacial spine, most of the time you won't find anything. If at all you find a vascular loop, seldom you find rarely you find acquisitionoma. But most of the time it is normal only, except for the vascular loop. That too occasionally. But in myokymia, always investigate.
This can occur as a benign also, benign myokymia.
That is only confined to one part only like that. In myokymia. It's continuously coming most of the time.
Eyelid myokymia?
Yes, he has also put not eyelid myokymia, it's on the orbicularis oculi, the facial muscle myokymia. What you find the lower part is the orbicularis, purple part of the orbicularis, that is producing this myochemic movement.
This persists during sleep also. This.
Yeah, that's what mother was telling. Mother was looking at him. He was telling that it was persisting during sleep also. So I think we can stop here. One more case, I think it's already time late. So any questions?
There any long tract signs in this case, sir? Oh.
Nothing. That is the funny part of it. He has not, even not a facial palsy is not there. Nothing is there. No sensory loss, nothing. No nystagmus, no long tract signs. That's the peculiarity of this low-grade astrocytoma in the pond. They infiltrate along the tracts and produce large mass. Unless it is late, they won't produce any, it becomes symptomatic. That's the peculiarity between adult brainstem glioma and the childhood brainstem glioma. In childhood brainstem glioma, it is more symptomatic, like 6th and 7th level. I mean, adult one, they slowly infiltrate like this.
Sir, can glioma
natural progression like years to progresses or years?
No, the prognosis is very slowly progressive. So in fact, I contacted neurosurgeon. He said, don't radiation. Even if you get radiation, that's going to produce a problem. Just leave it alone. It is go as long as it goes. Sometimes it can remain quiescent for a long period of time.
Sir, can myokymia persist during sleep, sir?
It persists during sleep. is because the origin is the peripheral. Just like hemifacial spasm, it can persist during sleep. It is coming from the irritation of the seventh nerve.
Okay, sir. Thank you, sir.
Usually dystonias disappear during sleep.
Yeah, it's not a dystonia, it's a myokemic problem.
No,
Dystonia
hemifacial spasm is a focal dystonia.
Hemifacial spasm actually is not a focal dystonia. It is again irritation of the facial muscles. That is why the loop is just like a trigeminal neuralgia. There is a loop pressing on the seventh nerve, producing ephaptic transmission and then irritation of the seventh nerve. Facial dystonia is different thing. That can produce, can disappear during sleep. Medication, I put them on oxetol or carbazepine, but whether it improves or not is not going to matter much. Okay, shall we stop?
The one last question, sir. The last patient, medial rectus weakness, sir. But despite the medial rectus weakness, there was no diplopia due to that muscle weakness, right, sir?
Initially, he complained diplopia to the left, then he complained diplopia to the right side. Anyway, you can see this diplopia more prominent, he must have forgotten about it. He should have complained. That is a history he got. But obviously, he's got a medial rectus disease.
Okay, sir.
Sir, because all the other movement disorders, like chorea and tremor, they're all from the centrally originating. They disappear during sleep, sir. Dystonia, then chorea.
Right. Usually, this all extemporal movement is as a class disappear during sleep, except some case of hemipalismus and palatal tremor. The palatal tremor also two types are there: the benign palatal tremor and the other one, symptomatic palatal tremor. Symptomatic palatal tremor due to the lesions of the Glenn-Muller triangle, they can persist during sleep. Secondly, some hemipalismus also can persist during sleep. Chorea also can recur on the REM phase of the sleep. So also tics. So generally, movement disorders, external movement disappear during sleep, but not applicable to all. But the peripheral origin, like this, the myokymia, neuromyotonia, or Isaac syndrome, those things, tetany, those things can persist during sleep. Stiff person syndrome, they classically disappear during sleep because due to the disinhibition of the anterior horn cells, the glycine receptor antibody, they can disappear during sleep.
So the young man in ptosis and medial rectus palsy, did he have weakness of the oculi also?
He did not have weakness of ocularis. In fact, I did not. If you want, I can show that because to save time.
No, I'm just asking.
Yeah, no, there's no weakness of ocularis.
Okay. Okay, so thank you.
Okay.
Thank you.
Thank you. Good night. See you next week.
Good night, sir.
Thank you, sir. Good night.
Good night, sir.
Good night.
Good night.
Good night.
Good night, sir.
Good night. Good night.
Good night, sir.
Good night, sir. ഷുവർ നമുക്കൊരു ദിവസം ഒന്ന് ഒരു ഗാനസന്ധ്യ ഒരുക്കാം. ഏതൊരു സൺഡേയോ സാറ്റർഡേയോ ആയിട്ടോ. ഓക്കെ, ഡെഫിനറ്റ്ലി രസമായിരിക്കും. അതുപോലെ ക്ലബിൽ എല്ലാ സൺഡേ വരണമെന്നില്ല. ഞാനും എല്ലാ സൺഡേ ഒന്നും പോകത്തില്ല കേട്ടോ. നമുക്ക് ഫ്രീ ആയിട്ടുള്ളപ്പോഴൊക്കെ ഞാൻ പോകത്തുള്ളൂ. പിന്നെ ഇങ്ങനെ നിർബന്ധമൊന്നുമില്ല. പിന്നെ അവിടെ ഭയങ്കര പാട്ടുകാർ, നമ്മളെപ്പോലുള്ള സാധാരണ പാട്ടുകാരൊക്കെ ഉള്ളൂ. എക്സെപ്ഷണലി ഉള്ളാവുന്ന 2-3 പാട്ടുകാരേ ഉള്ളൂ. ബാക്കി 10-35 അംഗങ്ങളുണ്ട്. അതിനകത്ത് എല്ലാവരും വളരെ ആവറേജ് സിംഗേഴ്സ്, ആവറേജ് അബവ് ആവറേജ്. എക്സെപ്ഷണൽ സിംഗേഴ്സ് 1-2 പേരേ ഉള്ളൂ. നമ്മൾ അങ്ങനെ അതുകൊണ്ട് അതൊന്നും പ്രശ്നമൊന്നുമില്ല. ക്വാളിഫിക്കേഷൻ, യു ആർ അബവ് ക്വാളിഫിക്കേഷൻ മാറി തരുന്നതാണ് എനിക്ക് തോന്നുന്നത്. ഓർ യു വിൽ ബിക്കം വൺ ഓഫ് ദ ടോപ്പ് വെൻ യു കം ദർ എന്നാണ് എനിക്ക് തോന്നുന്നത്, എസ്പെഷ്യലി മലയാളം സോങ്സിൽ. എനിവേ നമുക്ക് പ്ലാൻ ചെയ്യാം കേട്ടോ.